Good afternoon to one and all. Thank you for this. Thank you to Palliative India for this opportunity. It's a learning process. All of us together, we are going to see what best we can provide to the community and to the world as such. So without much ado, we'll get into the program. Shall I start sharing my screen?
Yes, ma'am, you have the sharing rights. Please go on.
Okay. No, it says only the host can share screen in this meeting. That's what it says. Can you just check that, dear?
Yeah, yes, ma'am.
Ma'am, please
Check it again.
Can I try now?
Yes, you can.
So I have a small request. Please switch on your video and attend the session.
Can you all see my screen now?
Yes, ma'am.
Okay. Good afternoon to one and all. In the next 30-40 minutes or so, we are going to see and understand what is palliative care, what we can get from this session to help us move forward. The word pallium is derived from Latin. What does that mean? It means to cloak or to cover. Then comes, what is the Oxford Dictionary meaning for that? Means it is to relieve without curing. That is the verbatim meaning for the word. Next, before going into in-depth, first we need to see why this importance has risen. So we'll see a little bit of statistics and significance of how palliative care as such started. So from that point of view, generally, many years ago, communicable diseases were the main issue. But in today's world, non-communicable diseases like cancer, dementia, renal failure, they are all increasing in leaps and bounds, not as anyone expected. So, and the expected or the anticipated number, what figures we are getting are generally about 1.5 million people all over the world are in some form of chronic pain. And next, the next big alarming number is about 61 million people are said to endure unrelieved from what we saw, the non-communicable diseases like either cancer, dementia, or renal failure. They are undergoing some form of unrelieved serious healthcare issues. And this is there not in one part of the world. This is a global issue. This is a hue and cry from all over the world. So, and this 61 million is a very big number. So all of us can't sit or stand back and say, oh, can't watch this. We have to enact and do something for this. So that is why there's a need for some form of care. So that is when and how the whole palliative care has risen. And we'll see a bit more about it. And next point is that something, see, in all medical school or nursing school or whatever it is, we are all taught about, okay, disease management, cure. We are not taught or thought of death, but that is also part of life. So we have to understand that death is inevitable. No one on earth can change it. But today's era, we have started giving importance for something else also. A big, important golden statement, quality of life. All of us want quality of life. So that is where the role of palliative care has come, which helps to improve quality of everyone's life, and why not the quality of life of someone who is in the stage of dying too. So that is where the importance has come. And then we are trying to help through palliative care and deliver or give some form of better quality of life, not only to the patient, also to the carers and family. So we are taking into in total. So that is the importance and significance of palliative care. Next, definition. Palliative care improves the quality of life of patients and that of their families who are facing challenges associated with life-threatening illnesses. And it could be a physical, psychological, social, or spiritual need. And also, as I mentioned before, the quality of life of carers also improves. That is important. See, when we go into a little bit more detail, we'll see, because it's just not the patient, it's the carer also plays a big role. So both have to be looked after. Okay. Broadly speaking, palliative care could be either a home-based care or a hospital-based care. Both are equally important, and we will see about both. Next comes history. How and like little bit of history about palliative care, how it started, or where it is today. So initially in the 50s, Dame Cicely Saunders was an important person who started or initiated this whole thing. Basically, she started articulating on ideas about care for the dying. So that is what started in the 50s. And then in the 60s, there was a psychiatrist in the United States called Elizabeth Kubler-Ross, who wrote a book on death and dying. So that is how people started thinking. This is a little bit of awareness. Awareness is brought out. So that book and the significance of these, see, many times people are scared to talk about death and dying. So these two incidences just opened up the ideas. And then in the 70s, there was an oncology surgeon in Canada who started initiating, and that is when the word palliative care was coined. And next comes in 2006, the American Board of Specialties recognized palliative care as a specialty. So it was incorporated into medicine and fields like that. So these are the little bit of history. And then how things are happening now is that it is considered that palliative care also has to be incorporated into the medical curriculum. Different specialties have to be aware of it. A multidisciplinary approach has to be done. So slowly they are including this also as part of medical, all forms of curriculum, increasing awareness, and then having education programs. So that is how from the 50s, it is slowly increasing, developing. And WHO has done a lot for this. And even in 2020, they've upgraded and given fundamental key factors and things like that. In 2020, August also, WHO has done some update on what the whole world together can work towards delivering a better palliative care service. Next, we will look into the fundamental aspects of palliative care. What all is palliative care going to provide? It provides relief from pain and other distressing symptoms. We will see about each of them in due course. It affirms that life and regards dying as a normal process. So as I said, people were scared to say, but people have to understand that it is not something abnormal. Don't get scared. If it is just by raising awareness and telling them, giving them a little bit more information on that. So they were unaware, did not know. So once you know, all of us are the same. It is only fear of the unknown. That fear is only fear of the unknown. Once you know, there's no fear. So that is something which is the second point. Next, it intends. This third point is very, very important. Intends neither to hasten or postpone death, because this is very, very important factor to be understood, because that is where the myth comes. So if everyone understands this, palliative care is not doing that. It is not going to hasten or postpone it. None of that aspect is there. So this point is very, very important to understand and take home as a take-home message. Next, it integrates psychological and spiritual aspects of patient care. Why? I will tell, because there is study and data and statistics to show that these two elements play a big role in palliative care and in patient outcome also. Okay. And next is it offers a support system to help patients live as actively as possible until death. See, every one of us, this is not just to see as a patient. We can all put ourselves in that shoe. All of us want to do the best until like my last breath. That's the general intent. Okay. So for that, palliative care helps. Next, it offers support system to help the family to cope during the patient illness and in their own bereavement. So it is patient-centered, but after bereavement, the whole impact goes on to the family. So the family has to be prepared, helped to manage the situation and looked after bereavement. So either looked after by us or trained to be and have a better quality of life after the process also. So that is where the WHO, as I said, the WHO factors have also incorporated this. That is how the importance and delivery of palliative care has constantly been increasing and improving. And next is it uses a team approach to address the needs of the patient and families, including counseling where and when indicated. Hence, it will enhance quality of life and may also positively influence the course of illness. So it's not dull and doom all along. So it will improve, and once people are aware, and as I said, the spirituality element of it gives the patient and family a better thing. And so to our surprise, it might be taken entirely in a better way also. What also palliative care does is applicable early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and includes those investigations needed to better understand and manage the situation. So this I will depict with a graphical representation in the later slides. So to show that it is not, palliative care is not something which is given at the end of life care. Okay, so it is entirely, it goes hand in hand from the time of diagnosis. So that's where it is not to be labeled as something different. Hospice, end of life, it is not that. It is also a specialty which goes hand in hand from the time of diagnosis along with the patient and family. Generally, life-threatening illnesses like cancer, neurological, respiratory, or cardiac illnesses are said to have various implications. As I said in the beginning, we will look into these individually. It could be a physical factor, social factor, psychological one, or a spiritual health. This is all, again, this could be for the patient and the family. So all these factors individually, and also considering it in the perspective of the patient and the family. So we'll look at each in detail. Physical aspect. See, as in general, in any medical field, like anything will have symptoms. It could be physical, and it could be a sign, symptom, and different aspects of it. So in these, there are some things particular to palliative care. Of this full list, which I've listed, pain and shortness of breath are very significant, and they form a big chunk. That we will see how it is managed. The rest, for example, if you take poor nutrition and weight loss, that is one of the very, very important factor if you consider malignancy. Similarly, it could be an important factor for any life-limiting illnesses, chronic illnesses, because in chronic illnesses and in cancer, what happens? Basically, there's so much of fatigue, muscle loss. Basically, they don't have the energy to eat, to gain energy. So this poor nutrition and weight loss are important things which have to be understood first by the patient and family, and looked at how are we going to manage. A simple example I will give. Generally, any adult would be used to eating twice or thrice a day. Okay, but that exactly won't work in a malignancy patient, because first, loss of appetite is one of the symptoms. So they can't eat, they won't feel like eating. So first change, what you have to do, you have to make small meals, small frequent meals. Rather than eating 2 or 3 times, they may need something every 2 hours. and they may just take like 100, 200 mils. So see, the whole aspect itself has changed. But by doing so, giving nutritive, small quantity, quality meals frequently, that can be managed very well. So like that, I gave an example of nutrition and weight loss, which is one of the physical symptoms. Like that, each one of them, infection, dehydration, just they may not be able to drink a lot of water. Just having like a small ice cube or a pineapple piece in the mouth and having it and sipping it or doing something like that will keep them hydrated. See, why am I giving clinical examples? Because that is what you will remember and that is what will come handy for you to use in day-to-day practice. So like that, each one of them, nausea, vomiting, giving medications to avoid nausea, vomiting ahead, not to wait for the patient. Okay, for this, again, a very nice example. You start someone on morphine. Morphine is said to cause nausea, vomiting. So we have to work our heads around. When you start, going to start someone on morphine, you give them some antiemetics before. First, as I used to tell them, even wake the patient at 5 o'clock, give the antiemetic, give 45 minutes time so that you give the medicine, so that if nausea happens and puts the patient off, they won't even take the painkillers. So these are all, it may sound very simple and very small thing, but small things only take you a long way. Like that, these physical symptoms, each one of them have significance and they are particular to this form of illness. Okay, so like that, and tissue viability, wound care, everything. I can just go on and on this, but I'm not going to. That will be covered in another session for you. So managing these symptoms in a multidisciplinary setup, teaching them. Okay, as I said, for nutrition or wound care or anything, help them, teach them what are the home-based or what is feasible for them to do, and then tell them try managing like this to the patient and to the caregivers. So you're teaching them how to manage the symptom. And by communicating this, so you're helping the family. And also next thing is that to explain to them how the condition of the patient may change through the illness. And when they're approaching that, what are the symptoms they're going to have? And if you tell them, either the patient or the family, so they're prepared for it. And so we not only teach them these, we are going to tell them how to manage them also. So they'll be happy. Oh, I'm not just going to be scared. I know how to tackle that also. So the physical aspects, what is it, how to manage, how can they manage it, everything. So individually, we are looking into it. So they have a better quality of time, even at the time of death. So that is what is this. Next, psychosocial and spiritual aspects. Emotional distress is a big thing. So that why fear, depression, worthless feeling. Oh, I can't do anything. I am depending on everything with someone. So why on earth I should live? This is what will be running in that person's mind. So we have to tell them, no. That is where the role of family comes. The family is willing to help them. They say, don't, if you just tell the family or the family person jumps into help. So, and the person who is ill also will feel, oh, it's my son or daughter or whoever it is. So they are only happy. So it's just building a communication and a rapport between both of them will bring down the psychological element completely. So psychological, and then this can be again approached either through counseling sessions, psychological psycho-oncology sessions, or psychologist sessions. Just by sitting and talking to them, listening to them, that itself may give them so much relief. Next comes spirituality. Spiritual assessments are all done because why? Each area, regional differences are there, various beliefs and concepts are there. We should respect everything. Don't belittle anything on earth. Okay? Respect them. See, if you respect, part of our job is made easy just by active listening and respecting. And then comes, there are, as I mentioned to you, there are a lot of studies which have shown, basically they've seen on quality of life. People who have some spiritual belief, what big difference between religion and spirituality? Religion is just some belief and practices, whereas spirituality is something different. What is spirituality? It is seeing meaning of life. What is the purpose of my life? So people who have some beliefs in it have found that those type of things, if someone has, they deal and manage the palliative care situation better off. So if people are willing, or if they want some help in that regard also, you can provide, and that is said to reduce the distress in a very great level. So coming to what is the aim? Aim is to support the patient and family wherever it may be it in hospital or in home. What for we are doing this? To improve the quality of life. And finally, to enable a dignified death. I used to say, when we are alive, we look at our dignity in a great respect. When we are dying also, we have to give great dignity to that soul. Okay, so the dignity of any person has to be maintained all along. Not even an iota of reduction in that should happen. And we all should try to deliver that as much as possible. Okay, what are the common barriers in palliative care? See, most of this are from the WHO information, and this is the latest information I'm trying to convey to. See, all what I'm telling is a global thing. Not one place is better off, one place is not better off, nothing like that. These are barriers met all over the world. So national health policies are not including palliative care in their system or anything like that. And there is no specific training. Most of it is done by private, whereas this is not incorporated as part of the curriculum or anything like that. So these are all issues faced by all over the world. So, and third point is this access to pain relief, opioid pain relief is a very, very big issue globally. They say only like 5-10% or 15% also in the whole world. See, either difficulty in obtaining opioid is there, or if the opioid is there, delivery to the point of care of the patient. So there are difficulties in both. So this is a barrier met by the whole world. So that's why even in latest statistics, they say 10-13% only in the whole world it is available. Next, what are the other barriers? As we have seen, lack of awareness. Many don't know, oh, do we need to have palliative care as part of it? So even there are people like that. Not only general public, there may be some doctors also. It's not to deny or degrade or anything like that, but that is because this specialty was not given as so much importance before. And then next comes cultural and social barriers. Each one's beliefs and things are there. And myth and misconceptions have always been there. As I said, no end of life care, that is different. Palliative care. First thing is awareness and educating everyone what it is. So misconceptions, if that is taken away, and the availability of opioids is made sure, that will help. One more point with opioid use is that when opioid use is introduced, people always have this idea of substance abuse, whereas the amount of opioid that is used for pain relief and the oral route which is used will not lead someone easily to substance abuse if it is used appropriately. This has to be conveyed by the medical team, like be it the nurse or doctor or anyone, to the public, so that they don't deprive the patient of giving that and having a better quality of life. As I've seen many patients that I've seen and dealt with, as it was mentioned in Adair Institute, I've seen them just to be started on, and in about 4 weeks' time, it will be a totally different person coming who was crying, and I was not doing just what? Only 5-10 milligrams of morphine, 4th hourly. And after a few days, they themselves, they won't keep on increasing. They'll say, I'm so much relieved. I'm able to, someone who was not able, for example, there was a 60-year-old person who was with lung cancer. She was literally not doing anything. She said, oh, I'm able to cook and do things now. I'm feeling so much better. So it does make a big difference. And it is small dose, no need to be worried about misuse and things, substance misuse and things like that. And what is next? What is the WHO recommendation to improve or overcome these barriers is the health system should integrate palliative care in the structure, and also did have some separate funding or financial support for it. And it should have policies for training or training the professional, allied professionals, everyone on palliative care, and also have option for volunteering. So even younger people could be exposed to this as one thing. So as a voluntary service, they can do some role in palliative care services. So, and then medicine policy for the availability of opioids. So next comes, what is the significance of palliative care? See, this part is maybe like a repetition. Palliative care is most effective when considered early in the course of illness. Early palliative care not only improves quality of life for patients, but also reduces unnecessary hospitalizations and use of healthcare services. See, this is very, very significant because it has to be hand in hand. So where it can be used, where it is not going to be, for example, as I said, if you have it when the patient comes into hospital itself, okay, they're going to have some chemotherapy, radiotherapy. They're going to try that. If that is beneficial, go ahead. If it is not beneficial, for example, it is stage 4 of the disease, or no need to take cancer. If it is some form of chronic respiratory illness, they have reached a stage where they are plateauing or coming down. They are not improving with any form of medication. All forms of curative management are not responding. So those type of patients, what are we going to do? We are going to do different type of care. We'll give them better quality of life, maintain their day-to-day living. So that is where, so this, to reduce unnecessary hospitalization and use of healthcare services, that is what it is trying to say. Come, this is what I've been telling from the beginning. If you all see this diagram, see, initial, on the left-hand side, you have presentation diagnosis. At that point, you have curative, life-prolonging, everything is there. They are all forms of whatever is available, they're going to try. In that itself, whereas see, the yellow block is the palliative care. So see where it starts. It starts there at the presentation, but it is not forcing them to go into end-of-life care. In the left end of the screen, if you see, you have disease-modifying therapy making the bigger chunk. Their palliative care yellow element is very small. So they're there in the background. If you need, we will help you. Then as the disease-modifying method is used, if it is beneficial, that takes a bigger role. If that is not beneficial, only palliative care comes in. Okay, so this one and only thing from today, if you want to take, means this is the diagram, I would say. Try to put it, understand and have it clearly. So it is a hand-in-hand team. So we'll work together. If disease curative management works well and would keep on going, we will help you. If that is not helping, because we are there already in the background, we can jump in and help them. And not only once we start, it goes on up to if they need care at the time of death, and bereavement is also taken. So this is a complete, in total, it's overall care. It's just not one aspect. So this is an important thing. This is palliative care. That is what I would like to convey. And it is represented very well in this diagram. And as I mentioned, pain and difficulty in breathing are the two most frequent and symptoms which form a bigger chunk experienced in patients who need palliative care. And opioids are essential for managing pain. And for next point also is very important. Opioids can also alleviate Other common distressing physical symptoms, including breathlessness. This is again a very important thing, which is slowly being it's been used. I have myself used in some patients, and it does wonders. Use of opioid for breathlessness is a very, very minute dose, 1/4 the dose. So, for example, as I said, 10 milligram, we start from 2.5 or 5 milligrams morphine. And with that as a 1 or 2, once daily, twice daily, or max thrice daily dose, they will get relief with breathlessness. So that is controlling such symptoms at an early stage is an ethical duty to relieve suffering and to respect a person's dignity. So this pain and breathlessness are the big chunk, and both of them can be managed with opioid very, very well and give a better quality and dignified life to a patient. Because see, helping patient is our duty. Why have we all studied or done this profession? My first aim is to do something in patient's best interest. So what can I do to make them comfortable and get a smile on their face? That is my aim and goal. Just now a brief information on hospital-based care and home care. Hospital-based care, basically you have a setup in the hospital. As I said, it would be there in any, as a entirely separate palliative care hospital or a hospital which has palliative care service also. And it does have a multidisciplinary team. It will have a psychologist, social worker, physiotherapist, all working towards the welfare of the patient. And the extra nursing needs and things like for wound care, minor palliative care procedures like a ascitic tap or something what you need to do, or a dressing, all these are done. So all of the above are available in one place. That's what is hospital-based care. Next, home care. Home palliative care is a form of palliative care that provides basic needs. As we have seen, physical, psychological, moral, everything to the patient who is suffering from a chronic illness, as we have seen, like cancer or cardiac or renal problem at home. What does a home care provide is provided by a trained multidisciplinary team of doctors, nurses, social workers, physiotherapists, volunteers, everyone. And as for the need of the disease progression. So everyone is there. And I'm not going to go force everything on day one to that patient at home. We will do what is needed when needed. And next thing is important. This care provided at home is in part one received in hospital. Why? Because the whole team is trained in such a way that nowhere this is lesser or in any way like that to the care provided in the hospital. So the full team is trained, educated, and prepared to manage things at home. To what extent can be done? So you can't argue, oh, what is done in the hospital. So we'll try to do what can be done, because for everything, there are some simple methods which could be done. And see, as human beings, we have the ability to think and do many things. If we think and do things in the right way, we can achieve success even by providing good care at home. For that, Palliative India is a big example. So the importance, what is the difference or benefit of home care? The first part is from the patient's perspective. What is that? Peace of mind. What every one of us want is, I want a peace and quiet thing. And when someone is in their own atmosphere, our home is the best. Home, sweet home, we say. So like that, if someone is going to be happy, where that person will be happy will be at home. And everyone wants to be with their near and dear ones. And that also is possible at home. And especially when someone is going to die, they would say, this also has been proved statistically. They've done so many studies and asked people. They say 8 out of 10 or 9 out of 10 will say, I want to die at home only. Then patient gains confidence when he's getting his treatment at home, and the family members are taking active part of it. Not that nurse or doctor is going to help and they're going to be unhappy, but if it is my own kith and kin, I feel more comfortable. So all these patients' perspective are met when the care is provided at home. And from the carer's point of view, the role of family members who want to come and help their loved ones is taken care of. Or the physical, psychological, financial needs also, no? can be considered, what is possible, what they can tailor make some things to their needs. And then the home-based care services ensure continuity of care, and it empowers the caregiver and the family by teaching them. See, as I said, there are many ways, like wound care, bed source care, all that we can teach them and do wonders with that. Okay, so, and by doing that, and then the patient and the family have very much of satisfaction by doing so. So finally, what is the success tool after all this? We have seen in the last 30-40 minutes so much of information. So all these information have to be assimilated. Then in different forms, either by training, education, all that, you get all the information. So the information both for the doctors or allied professionals or volunteers, everyone, we have to share the information through some form, either education, training, or something like that. Then communicating it to them and to the family, and implementing some behavioral changes in see, these are all palliative care, or palliative care as such has got information which are very, very sensitive about death or personal issues. No one wants to reveal and discuss with everyone. So we have to understand the significance and importance of it and give due respect for it and deal with it appropriately. So if you do that, that is where you will get that, and once that is implemented, then you will have good success. And communication has an important role to play. How you're going to say, what you're going to say, so that this picture gives us a rough idea. What information we are going to give should be correct and complete. No halfway information, or you use jargons and things and what the patient or the family won't understand. So it has to be simple, correct, complete, and concrete. Oh, it shouldn't be something very doubtful. Oh, what they are telling is not clear. So that has to also be there. So the concrete and clear, what are they? It has to be precise, clear. Then coherent. It has to be relating to, you don't talk something irrelevant to the situation. Okay. And last but not the least, it has to be courteous. You can't put rules. Oh, this is what I say you have to do. No one will follow. Even you and I won't listen, isn't it? If someone is enforced on us. So all these form an important element. So finally, what are the learning points that we have gathered today? Early involvement of the multidisciplinary team plays a very important role in overall patient satisfaction and well-being. Patients should be given full autonomy to make informed decisions, and their confidentiality be strictly practiced. Okay? Early involvement of psychological, spiritual support is associated with improved mental health and a better quality of life. The families and caregivers of patients should be kept informed and involved throughout, and the opinions and views taken into account and respected too. It is important to treat distressing symptoms at the end of life. Thank you to one and all.
Thank you, ma'am, for the wonderful session. Anybody have any doubts regarding this session, please ask madam.
Shall I stop?
Yes, ma'am. Yeah.
Okay.
So anybody wants to give any suggestions or comments, you can unmute yourself and talk, or your questions or comments in the chat box.
Hope the slides and everything were clear and
yes, ma'am.
Okay. How many participants are there in total?
There are 32.
Oh. And how many have worked in palliative care before? And how many are totally new? Is there anyone who has worked in palliative care before?
Anybody have any experience in palliative care before? No.
Okay, then it's a good thing. So it is something they are interested. That is why you've thought or got the idea of attending this one. So it's a good start then.
Okay, we can move on to the patient story. Before moving to the patient story, I'll like to highlight few things about the today's sessions. As Madam said, like palliative care should start from the point of diagnosis. So whenever you start, if you have a chance to start palliative care at the point of illness, definitely the journey will be more easy than less palliative care. If you give a proper supportive care from the beginning, then we can able to control we can able to relieve their sufferings, and also we can able to support the family too. So if a person's get an illness in the family, the whole family will be affecting. So that is why we palliative care said palliative care is not only for the patients, it's for the family. Okay, so palliative care is for any serious health related persons. Yeah, we should get palliative care. So not an end of life care, not cancer patients, not for HIV/AIDS patients. It's for any patients, any serious health related suffering patients should get palliative care. And also palliative care is a teamwork. So multidisciplinary teamwork is mandatory for that palliative care, because some patients need doctor support, some patients need nursing support, some patients need physiotherapy supports. There are a lot of things. Some patients support needs psychosocial issues, maybe give some psychological support. So that time we need, sometimes we need medical social workers help. So if they have a lot of psychosocial issues there, try to include a medical social worker in that team and explore a lot of the more problems and try to relieve their psychosocial issues. That way we can able to improve the quality of life. The main aim of palliative care is to improve the quality of life of the patient and their family. And the second most aim, the main aim of palliative care is to relieve pain and other symptoms. So if you are able to control their symptoms, definitely we can able to improve the quality of life of the patient and their family. So this is how palliative care. So we need a good teamwork to improve palliative care, and also you have to share your knowledge with your colleagues. That I know also that most of the medical persons will be thinking like palliative care is only for end of life care and only for cancer patients. So you have to share your knowledge with your colleagues and neighbors and friends. So that way we can able to make awareness, maybe aware about palliative care to your medical professionals too. So once the medical professionals should aware, we can able to that implement palliative care everywhere. So all that specialty needs palliative care. So we need to try to implement palliative care everywhere, so that every person should get good palliative care and effective pain relief management. Okay, so we can move on to the case presentation. Today, Reshma, who is a staff nurse working as a session head in home care department here. She will be presenting a model case presentation today. So based on this, you can listen how she is presenting the patient story. So maybe next week onwards, you have to present a patient story. One of the participants should present a patient story. Okay, thank you. Over to you.
Thank you. Good afternoon to all. I am Sister Reshma. Today we are discussing a patient story of 39-year-old male, diagnosis traumatic quadri paralysis with stage 4 pressure sore over sacral region and left gluteal region. And the presenting complaints are patient complaints of constipation since 2 days and have complaints of bed sore over sacral region and gluteal region, complaints of moderate pain over the hip region, also urinary leakage. About the history of presenting illness, He had history of fall while carrying weight followed by neck pain and weakness of both limbs and was diagnosed with traumatic quadriparesis in August 2015. And he got admitted in government hospital and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region. It was stage 4. And patient complains of history of pain over the hip and wound site for more than 2 weeks. About the pain over the hip region, he complains of bilateral complaints of the pain, and the pain score was 5/10. Pain is intermittent in nature and burning type of pain. Also complains of pain over the wound site. The score was 4/10, continuous in nature and throbbing type of pain. Due to this, sometimes they kept the wound open. Sleep was disturbed and oral intake also decreased. Next is about the examination. Patient was conscious and oriented at that time. Vitals are within normal limits. Next is about the pressure source. Pressure source are warmth and tenderness present, exudates present, tunneling also there. They are irregular in shape and foul smelling. And treatment and significant investigations after admission. We done routine investigations for him and all parameters are within normal limit. About the psychosocial aspect, 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring them, not helping them. And he was a manual laborer and he was the breadwinner of his family. Now his mother is a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wages, her pension and some of his friends. Have taken rupees 1.5 lakhs from private finance bank for the treatment purpose. They are devout Christians, now unable to go to church. This makes him very sad. He communicates through cell phone. And he says to his mother like, I don't think I can walk. So please don't spend money over my treatment. And the main concerns are pressure sore, pain, and the financial problems. The summary, the 39-year-old man with traumatic quadriparesis with bed sore present over the sacral and gluteal region with pain over the hip region. The pressure source was stage 4. And the discussion points are, do we need to provide palliative care for this patient? And what are the problems faced by this patient? What all can be done for this patient and his mother? These are the discussion points.
Thank you, Reshma, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. So otherwise, we can move on to the discussion points. Okay, thank you. We can move on to the discussion points. So we had a wonderful session on palliative care, and we had listened a patient story. So do you think this patient need palliative care? So we would like to hear from you. Anybody? So we need your answers. Please unmute yourself and talk, or you can put your answers in the chat box. Do you think this patient needs palliative care?
Yes, as Shiva says, you all have to speak. Either you can't, you don't want to speak, put it on the chat, because only an interactive session will help you all to think parallelly. Each one of us have different views and ideas. So either you unmute and speak or put it on the chat. Something that interactive only will help you all.
Yes, ma'am, this patient needs palliative care.
So few answers came, yes, he needs palliative care. So why do you say yes? Why this patient needs palliative care? So most of you are thinking about thinking, okay, this patient needs palliative. Why do you think like that? For better health and prospective life. Any other answers? To improve quality of life.
What is the primary reason that he needs palliative care? If you think in that perspective, you will come to answer why, her question of why.
So one of you said religion and spiritual needs, and Bagana ma'am said indeed to postpone of death for speedy recovery. Jonali said for speedy recovery, relief and improvement from pain. Okay. Previous slide. So this is the summary of the patient, 39-year-old man with traumatic quadriparesis with bed sore, stage 4 bed sore over the sacral and left gluteal region with pain over the hip region. Okay, so this is the summary. Now, his main caregiver is his mother, so old mother. So all of you are agree, okay, he needs palliative care. Okay.
1 minute, Shiva. See the diagnosis. Sorry to interrupt. See, the diagnosis itself is traumatic quadriparesis. He cannot care for himself. So that is one of the need, isn't it? For him needing some support. So the main primary diagnosis or the summary itself gives you a clue why he needs. Is that helpful, Shiva?
Yes, ma'am.
So that is where he is helpless. He cannot see. If he could look after himself, he will at least try. But this quadriparesis is pushing him to a situation where he cannot look after himself. So he needs. That is the primary reason why he needs. He definitely needs care. Okay, go ahead.
Yeah. So here, as ma'am said, this is a bedbound patient. He needs support always. Okay, he's a bedbound. So especially, why did he develop bed sore? Because of lack of care, because his mother is too old. She is not able to take care him well, because so he needs lot of attention. And here, especially the paraplegic patients, they are not able to move their own, but they are able to move their upper limbs. But they need to change the position, but they are not able to. So they need a frequent changing of position. They need a good support. So definitely this patient need good palliative care, good support, and also this patient you can think about from the patient side. So what are the aspects of care he needs? What is total care? What is total care? So total care is a physical, social, psychological, and spiritual care. So if you give a total care for these patients, definitely we can able to improve the quality of life of the patients. So not, if you focus on physical part, I'm sure we are not improving the quality of life of these patients. So we need to cover the 4 aspects of patients, the patient's problems. Okay, so here, let's see what are the problems. The next question, sir. So as you all agree, this patient needs palliative care. The first question is, okay, we understand this patient needs palliative care. And the second question is, what are the problems faced by this patient? Financial problems, yes. Then spiritual problem, okay. Problems in activities of daily living. Okay, he is not able to doing her even self-care also. He was not able to do it. So he need an assistance. So lack of caregiver support because his mother is too old. And then economic, spiritual, and psychological support. Again, okay, physically not able. So what is the physical problem?
Physical problem, ma'am. As her mother is old age, she can't improve his nutrition level to improve the health.
Okay, thank you. So I was asking what is the physical problems? What are the physical problems faced by the patients?
Physical problem, ma'am. He is unable to move. He can't take position himself. So that is a big physical problem because he can't move himself alone. He always need assistant to give him side, care for as we have to apply on. He has a 4th stage bed sore. We can apply 5 pillow rules for positioning, but as he is paraplegic, her mother is old age, so he need a assistant to do all these things to improve his physical health.
So, madam, over to you.
Yes, see, the important thing, what to be considered here are bed sore. Any bed sore care, what needs to be done? First thing is that turning the patient. Patient has to be turned regularly. First, wound care.
Wound care.
Exactly. What?
Ma'am, wound care, we can give oxygen therapy and we have to apply air mattress.
Correct. Everything. So total wound care is the full element of it first. To start off, put him on a air mattress, water mattress, or some mattress so that helps to change. So that is one thing. And then on top of that, tilting him, aerating. So by tilting or moving him, putting, as she said, putting pillows on one side, tilt him to one side for an hour or so, and keep a fan or something on the other side. So then in 2 hours time, he has to be moved again. So first, nursing and wound care, then comes nutrition, everything, general care also has to be. So this is main thing is wound care. This is in total nursing care. Okay, and then that, yeah, and changing or changing sheets and doing things for him on a regular basis. So I would say 60% would be on wound care. Then comes next element is, okay, you give wound care, but poor nutrition will not give. So you have to give him some form of good protein for healing what we need. That is the next thing we are going to see. So from that point of view, if you see, next is after wound care, nutrition. Then nutrition, either, see, now in this situation, mother is the only person and mother is the only breadwinner also. She can't make food and give him regularly. So that aspect also has to be considered. And then next comes psychological, social, spiritual, and financial. So this, in total, the three answers for the questions, I would say, first, he needs care. Then next, what? He needs care because he's unable to look after. So in total, full nursing care is needed for him. Then comes this financial, psychological issues, both for the patient and the mother. Because he doesn't have anybody else other than the mother, he is upset. So for first, doing some counseling sessions, both for the patient and the mother. And then next, looking at some financial aid, if possible, for them. Or looking at, see, in palliative care services itself, there are so many varieties of services nowadays. So there are some who have a very big heart and do it entirely on a charitable basis. So can we find through some social care or something, can we find somewhere where with minimal financial support, he can get more help? So this is in total. So this is really a wonderful case, dear. Even though it is for the beginning, so it will make all of you think, because this case as such has got proper nursing care needed. Financial support is not there at all. Only see a 60 plus person, how much they can earn compared to a 30-year-old. Okay, because that 60 plus person is physically not able to work as a 30-year-old. So we have got all challenges in hand to face. So here only comes the role of other. Now, out of the box, we say, you have to think, okay, the mother, son, and one support is not enough. So we have to tell them through, as you said in the conversation, by spreading word of mouth. Shall I try? Will I be able to get help for this person from somewhere else? Is there any other organization willing to help? So all that has to be thought in mind. Any common organization. So telling through someone, so is there some fundraising, someone can help? Because somebody may be willing to help, not knowing where to help. So if all those things fall in place, it might be very handy for this patient and the mother. So we have to look at all these things. Lot of counseling and things will be needed, both for the patient and the mother, because both of them are feeling helpless. He is feeling helpless, he can't do or work. Mother is feeling helpless, she has to work, but at the same time, she can't take care. So if you get some funding or some form of help, the mother may be able to take care of him 1 or 2 days in the week when she can avoid going to work and look after him. So like that, this really needs a multidisciplinary team approach. Social worker will have a big role to play. Any financial assistance, volunteers who can help. So everything, nursing, first nutshell means nursing, good nursing care, 60-70%. Then financial, psychological, moral support, all together is needed to obtain some form of dignity and better quality of life, both for the patient and the mother. So that would be an overall thing. And then there was one question in the chat box in that communication slide which I had showed. What is the difference between complete and concrete? It's simple verbal meaning, dears. Complete means there should not be gaps or missing element in whenever what you're communicating. There are 5 points to be said. Okay, I've said only 4. That is what complete means. Concrete means what? It should not be beating around the bush. What has to be taught? See, sometimes what we are telling, for example, any serious something about conveying the diagnosis. It is a very sensitive issue. So you can't miss. For example, you say it's the disease, you miss the stage of the disease or something like that. So it can't be like that. That is complete. You don't miss anything. Convey everything completely. And concrete, it has to be to the point. not something out of what you have to say, you miss and tell something else. So those are the two elements. You should not miss anything. That if you don't miss, it is complete. Concrete, what it is to be to the point, not something out of context. Hope that is clear. See, these are all different words and things we are trying to say so that we don't miss anything, because these are all very sensitive issues. And when we convey sensitive issues, our emotional element also might be there. So we don't give room for all those things. Those are things which have to be borne in mind. Ultimately, what we are trying to see, we want to give completely everything that's possible for the patient so that they get the benefit. As someone has mentioned, risk of infection, pain, everything. See, because if the wound care is not going to be good for the patient, recurrent infection. So a very important thing in this case, I would say, because he is with the quadriparesis, he is unable to move, air mattress or something like that will make a big help. So that this moving and tilting, even though it's not happening regularly, that air mattress does the job. So those are nursing care. This case is a big element of nursing care. If the bed sores improve, the pain will reduce. He himself, he can't turn, but at least less frequent turning. But in the whole run, he will need this form of care. Then next is we have to think, get physio element into it and see what stage or what is the power of his muscles, complete assessment to be done. And what is the range of movement or mobility can be obtained for him. So that in total, progressive, once the wound care is done well, progressive assessment and reassessment of his condition, and then taking it from there, what are the help to be done? That is the way forward it will be for this case. It's a case which needs help in all fronts.
Thank you, ma'am, for the valuable points. So, as ma'am said, this is a wonderful patient story because he has physical problems, he has social problems, he has psychosocial problems, and he has spiritual problems. So, if they have a psychosocial issues there, so their physical distress will be increasing. That we need to understand. Any patients who is having any psychosocial issues, definitely their physical distress will be increasing. For example, if they have a pain out of the 4 out of 10 pain there, so if they have a psychosocial issues there, when you do the assessment, definitely the pain score is high, 8 out of 10. So if you are able to find out their psychosocial issues, if you are able to listen their psychosocial part, definitely the distress will be comes down and the pain score is also comes down. So the listening of and exploring of psychosocial issues is very important. So we did many things for these patients. We'll show you what we manage, how we manage these patients, what are the things we did for his patients, for these patients. So Reshma will share you.
We already discussed the points. In short, what we did for this patient was, the first question is, do we need to provide palliative care for this patient? Definitely yes. As he is in life-threatening situation and he has serious health-related sufferings, and his quality of life is definitely affected due to illness. And we know palliative care is not only for cancer patients and end-of-life situations. It applies to any health-related sufferings, and the above patient story is an example for that. And the second discussion point was, what are the problems faced by this patient? We know he has physical issues such as pain, bed sore, urinary leakage, insomnia, loss of appetite, etc. And he has spiritual issues as mentioned in the presentation also. And he has a feeling of being burdened to the caregiver. And there are some financial issues because the patient was the primary breadwinner of the family, and identity issues was there, foul smelling all over his body, and social isolation, and a loss of independence and loss of job, anxiety, depression to be ruled out. And the third discussion point was what all can be done for this patient and his mother. We know in palliative care, community support is very important. So in this case also, community mobilization, we should facilitate community mobilization for regular visits and fund generation if possible. Then the patient was the primary breadwinner, so we can consider this family for vocational rehabilitation for the patient and the mother. And we should empower the mother to take care of daily care of him, like position change, bedsore dressing, etc. And we know the mother is the only one caregiver, and any respite for the caregiver for few days will help to give some relief for the mother. Then look at the health issues and emotional issues of the caregiver. We know in palliative care, we are not only focusing on the patient, we are considering the family as a whole. So we should give special attention to the health issues and emotional issues of the caregivers and make him feel that he is useful and convey that we care. Thank you.
Okay, I hope you all get an idea about palliative care. So how do we give palliative care and how we can improve the quality of life of the patient and all. So if they are able to do something for that family, you can think about the rehabilitation also, like physical rehabilitation and vocational rehabilitation. Sometimes because of the parents' illness, the children's studies may be affected. That time you can think about the educational rehabilitation also. You can find out the donors and support the children for education. So that is also, that is why we are telling about the total care. So if you are giving a total care of that patients, definitely we can able to improve the quality of life of the patient and their family. And also without family support, we can't do anything. So always try to include them in the care, and we have to listen their problems also. So always they are also suffering throughout the journey. The patient with the patient. So they are, the family is also, the family members or the caregivers also suffering. So we need to listen their problems also. Nobody is listen their problems. Always both them maybe. When we see that patients, if they are not giving proper care to the patient, to the patients, we used to blame the caregivers. So if so, we should not do like that. You have to listen their problems also. If they have any health issues there, you have to give some medications for that the caregivers, and make them free out of that physical problems. Then only they can able to care the bedbound patients. So here we need the good support. We need to give a good support, especially for the patient and the family. Okay. So, Madam, you want to?
As you mentioned, just one point I would like to add. See, the exactly very important point you brought up. The caregivers, in many situations, when someone is very sick and somebody is caring, they won't even tell about their problems. Yes. And when for example, someone is very sick and dies, at that stage, if you see, this caregiver will be in a worse condition. Okay, so that is why, see, in the talk also what, because everyone, this equal patient, caregiver, family, like two eyes, both eyes are needed for double vision or the 3D vision. So patient and carer, or patient and family, equal importance. So because many times, like that's a natural tendency. They will not reveal, oh, he is important now, let him be looked after. So they will ignore themselves. So we have to give importance. We have to teach them. That's why physically, whenever I used to say, you have to take care of them, take care of yourself. Ask us, oh, I'm having difficulty in this. Don't hesitate. Don't think, oh, this is a trivial thing. I feel ashamed to ask. No, it may be small, but if you leave it, it will become big. So in total, everyone, and so that is important, and giving respite for the carer. These are all very, very essential. They will get drained. 24/7, someone keeps on doing that, physical, mental. So all have to be considered, and in total, patient, family, all, total care is the only way. Now, today's trend, total care, multidisciplinary approach, only these work. One person doing, it doesn't work at all. See, simple example, in your house, all of you take house, work, all together only we work and achieve. Simple example, actually, mother doesn't cook, father doesn't go to work. How will children get food and money to do everything? So this is simple example which we do on a day-to-day living. Put that everywhere. Okay? Same, hospital, doctor has to see, pharmacist has to give medicine, physiotherapist has to give advice on muscle. If a doctor alone will it be successful? No. So everywhere there is team working, and team working has to be hand in hand. Oh, I am big, you are small. No, there's no I in team. So all of us work together, ultimately get success and happiness. If everyone works together and gets happiness, everyone gets happiness. So the same thing in every aspect. Take that and then implement it in nursing care or anything, palliative, all is the same. So that is what is important. Work together, get success, and all be happy.
Thank you, ma'am. Thank you. So, so we have learned many things today, and also whenever you have seen these type of patients, you have to think, put yourself in their shoes. So that is very, very important. You should work with an empathetic mind. So empathy is very, very important here. So we don't want sympathy. Sympathy can do anyone. So we need an empathetic mind to treat these patients. So always think from their side and try to solve their problems as much as you can. Thank you, ma'am. We can wind up the session.
Yes, thank you one and all. Good luck to the whole team of all of you and all who have started this course also. All of you do well, learn a lot, then go practice, enjoy doing anything. Okay? Do anything and everything happily. You will also be happy, you'll be successful, and the other end patient also is going to be successful and happy. So good wishes to one and all.
Thank you, ma'am. Thank you once again, ma'am. Thank you, Reshma, for the wonderful presentation. We'll see you next time. Thank you.
Thank you. Thank you.